We are live.
Good evening. September, as you know, is the Childhood Cancer Awareness Month, and retinoblastoma is the most common intraocular tumor, malignant tumor anyway. So, as ophthalmologists, we have a duty to share resources about retinoblastoma and also create awareness among ophthalmologists and also paramedical personnel as well as pediatricians. So, we have this special webinar today where we discuss retinoblastoma initially from the perspective of NGO who has actually been a game changer in the sphere of retinoblastoma in India, Can Kids Kids Can. Founder chair of Can Kids is Poonam Bagai, and she'll be speaking on what an NGO can do in the sphere of retinoblastoma to achieve certain goals in terms of life, eye, and vision salvage. Seema Das, who heads the ocular oncology service at Shroff Charity Eye Hospital, Delhi, will speak on a large study that we did with support from Can Kids. And that has given out a lot of data which are very emphatic in terms of the incidence and of retinoblastoma in different parts of the country and the stage at which these children present. Finally, I'll be speaking about clinical overview of retinoblastoma. That is the outline for today. That's the program for today. So I'll stop sharing and invite Poonam Bagai, who is the founder chair of Can Kids, to share her thoughts.
Thank you so much, Dr. Honavar. Always a real pleasure to be here today. It is Childhood Cancer Month, and what I'm going to talk about is the story of Fight RB India, a story that dates back almost 11 years now. I'm really delighted to be here. We have partnered in May 2024 with the AIOS with a view to creating awareness, sensitization of ophthalmologists for early detection and diagnosis of RB, for capacity building, for research and innovation, and for advocacy to the government. Thank you very much for having us here today. We are delighted with this partnership because it really, really helps us in our goal to actually save lives, save vision, and save eyes for children RB in India. Just very quickly about me, I'm a cancer survivor. I had colon cancer in 2000 and pledged to make a difference to the lives of children with cancer in India. Gave up my civil services job, came back and set up Can Kids Kids Can in year 2004. And this was our vision, to get to have global outcomes of survival for children with cancer. Well, that's 60% in general, but for retinoblastoma in the high 90s is what we're seeking. 100% access and financial protection for children with cancer and their families throughout the cancer journey, and securing the rights of the children to health, to education, to their childhood, to pain and palliative care, and importantly, their right to be heard. So we started, and this is very briefly about us, we started, as I said, in 2004, and today we partner with over 141 hospitals in 60 cities across the country. We registered back then 112, and today we support about 20,000 children each year, making it a total of about 135,000 families we have supported over the last 20 years. We raise funds. We're a society, so we're a charity. We raise our funds through CSR and other such initiatives, and we spend our funds on providing services and working in partnership with all the stakeholders. Those are our goals: 100% access to care. From the work we've done over the last 5 years, we've been able to drive access from about 29% to 45%. And our goal for 2030, which is aligned to the WHO and the Sustainable Development Goals, is 100%. We work on providing financial protection to families, reducing their out-of-pocket expenditure. And this is something we've done significantly for children with RB in the country as well. And as I said, 60% survival, but for RB, it has to be 94%. But today, I want to talk to you about retinoblastoma. We also work one cancer at a time. And our goal here is to improve survival outcomes through research and collaboration, awareness advocacy, service delivery, and supportive care. And my story then goes back to this wonderful gentleman called Dr. Santosh Honavar. He's our gold hero for his outstanding contribution to change for childhood cancer in India. We went to him back in 2014 and said, "Sir, please write up for us and tell us how we're going to achieve this. You're achieving high survivals in India. You're achieving, saving lives, saving eyes, saving vision. Tell us what we're going to do in India." And he wrote us this monograph. And this was back in April 2014. And this is something that we have followed as a roadmap. And it has been wonderful in terms of what, therefore, we have been able to achieve over the last 10 and 11 years. We set up Fight RB India together, and that was back in August 2014. And this Fight RB India became a stakeholder group, a collaborative group for individuals and institutions. This would be retinoblastoma treating centers, pediatric oncology centers, retinoblastoma survivors' parents, NGOs like us, donors and civil and corporate social responsibility partners. And over the years, methodically, we kept doing Fight RB India stakeholder forums. We kept pulling together a network of people who wanted to work together with us on that roadmap to actually fight retinoblastoma in India. So today, we are 61 partnering centers across the country. We have NGOs who partner for Fight RB India. We work in research collaboration with the India PHOG, and we have donors who support us in this initiative. What else did we do? We were therefore able to build this network, and you can see from this, these 61 centers are across the country, north, south, east, and west. There are doctors who are deeply involved in fighting RB in India. And with that, as you can see, amazingly, we are at about 1,400 children being registered each year in these centers. And in a minute, I'm going to tell you what that means. But meanwhile, in terms of the support that CanKids offered, we offer manpower to our treating centers in terms of social workers, in terms of psychologists, teachers. They hold the hands of the patients. They provide direct and indirect support. The social workers help to get access to government schemes, to provide information about government schemes. Our patient navigators help to create awareness and to hold the hands of the family so that they don't abandon. So service delivery is the third of the things that we actually worked hard at, and provided financial protection, provided out-of-pocket expenditure, give funding for transport, for accommodation, for place to stay, for food to eat. Many of the things, as we all know, that actually then bring down abandonment. So these are the services that CanKids offers when it partners with hospital centers, and it offers to all of you as well. Time for timely diagnosis, support for diagnosis, for the treatment, financial and social support, rations, hygiene, home away from homes, education for the children during treatment, continuity of care, survivorship, and essentially someone to hold the hands of the family through the cancer journey. In the last so many years of this project, we have supported 6,427 children, and we have spent about 8 crore rupees on this project. A substantial portion of this has been for service delivery and patient support. And I think that has been a big piece of the puzzle that an NGO can bring in. So with the stakeholder engagement, we've also worked on pulling together the network, and we've also worked on actually providing financial support and service delivery. What else did we do? We then realized, and it was in the roadmap, so nothing that we actually came up on our own, but we realized how important it was for us to do collaborative research on retinoblastoma. And the India PHOG came up about that time, and the very first multi-centered prospective collaborative study in India in the childhood cancer space was retinoblastoma. So with Dr. Santosh Honavar guiding us, guiding the team, we were able to start this INPOC study, and CanKids sponsored the study. This was the team, and I'm going to let Dr. Seema tell you more about the study. So I will not take too much time on this, except to deeply acknowledge the work that this team has done. I will not go through the data either, but roughly to tell you that the study covered 1120 children. And for us, as an NGO who's driving access, driving survival, driving financial protection, it gives very valuable information also for advocacy, also for saying, what do we need to do next? And this will guide us into the next, well, only about 4 years that we have for our target that we want to achieve. So I'm not again going to dwell on the key findings of the RB study, but for us, what was important was that the most important thing is early detection, early diagnosis. Our children need to be diagnosed early. And in a minute, I'm going to turn around and ask you, it's you who's going to help us do this. It is in your hands to detect our children and to refer them to that network that I've spoken about. And once the children get detected early is when we will not only be able to treat them, but we'll also ensure that fewer children come in at late stages. So what else have we done? We also worked on, okay, let's provide more sophisticated interventions, which not every center can afford. So I still remember, and I still wonder what brachytherapy is quite fully. Dr. Honavar, you've tried to tell me several times. I've read it up as well. But the fact is we supported brachytherapy. And then when we supported it in the South, across the network today, everybody is able to offer brachytherapy, which is so heartening. We're able to offer intra-arterial chemotherapy. We're able to do clinical genetics and molecular diagnostics. And these are now available at many, many centers across the country. So overall, in India itself, we have better and better treatment for children with retinoblastoma. And that is the power of coming together. It is the power of stakeholders engaging because they encourage each other, they learn from each other, they're able to cite each other, and that has, I think, in a big measure enabled where we are today in terms of RB treatment in the country. We have also, all of us, consistently worked on celebrating RB Week in May, on awareness at community level, awareness for beneficiaries, awareness for health practitioners. We have an RB directory. We've been creating IEC. And this we've done as a community and as Fight RB India, as well as individual efforts. And that, I think, has been quite key as well in terms of where we are today. So that's just a quick snapshot of the resource directory. And we'll share a link subsequently with the society, Dr. Honavar, and request you to share this across the membership so that people can know where to refer patients. We do survivorship work as well. And we encourage the survivorship work because once the children survive, they must thrive. A lot of the children with RB come in at a very, very young age, and a lot of them get enucleated, and many of them lose their eyes. Of course, our goal is no eye, no vision, no loss of either. But at the same time, they need support. We get them disability certificates. We work on survivorship and late side effects. We work on providing them Braille support. And this, I think, is critical, and going forward will continue to be more and more important as more and more children survive. The group is called Jyotirgamaya, and it includes institutions, professionals, CSOs, policymakers, survivors, and families. So the big good news, and this is where now I come to what we want from you. What is amazing to us is that out of the incidence of childhood cancer at 1676, this on our estimated national and state level incidence of childhood cancer paper, we today find about 1,400 children, which means that access to care in India for retinoblastoma is 83.5 compared to the national average of about 40%. To us, this is the biggest thing that we've managed to do. As a community, as the Fight RB India stakeholder group, for retinoblastoma, access is the highest amongst all cancers. And over the next 4 years, we want to get to 100%, which means we need your help to detect the kids early, to refer them early, to find these remaining children, and to make sure that we get them to RB treating centers the fastest that we can. And the number is not high, the numbers are low. So, often I remember when we first started, I said, Dr. H, will we actually get there? And he said, yes, if you follow the path. And I think we followed the path. I think we worked together as a community. And I think that this is the most heartening piece of news. But in the next 4 years, we need to find all those children. We need to make sure they all reach treating centers and they get good treatment. I've actually been through all our services, so I'm not going to take much more time on this piece, but really to come to what we want from you, which is join us in the Fight RB India. Your watchful eyes can save lives. So detect early, refer. The resource directories help you to know where in the country good RB treatment is being offered. But the number 1-800-123-6272 is a helpline number. If as an ophthalmologist, you come across a child and you feel that, this child could have cancer, the support that we're offering is for diagnosis, for referral, for supportive care, for accommodation, for transportation. Because you know what, guys, the number is not so high and we think we'll find them all. And that'll be so special for our country that we've actually cracked it with one childhood cancer. So we want to get to 100% access. We want every child to get financial protection. And this is part of our offer to you, that if you have a child and you feel the child needs to get somewhere, if you can get in touch with us, we will offer the support. When the children reach the centers, we offer the support. And our big ask to all those who do the research in the study is we want that survival to be 94% for all children, but certainly 80% RB for survival for retinoblastoma by 2030. And for this, as I said, we need your help, we need your support, and we need you to call our helpline number if need be, so that we can actually offer the support that is needed for the children. As ophthalmologists, you know this, I don't need to say this, but you are key in the frontline detection of retinoblastoma through your routine examinations, through parental education, through prompt referral, and collaborating with us and being part of the Fight RB India initiative. I also want to tell you that we'll be having a pre-conference workshop to celebrate 11 years of Fight RB India and the roadmap to 2030. We don't have that many years, just 4 years left, but we want 2020 vision for children with RB by 2030. And we just feel so confident that we're going to get there. But we know that your role in this is critical. And I cannot thank you enough, Dr. Hanawar, AIOS, for giving us this opportunity to talk to such a large membership of what is clearly critical in the fight against retinoblastoma in India. Thank you so much.
Thank you, Poonam. I think you brought it very loud and clear, the role of NGOs and what CAMKIDS has done to write the retinoblastoma story. I think something is playing in the background. All right. Okay. So, Seema, do you have any comments on this before you start your talk? You're part of the whole story, right?
I think Poonam has actually sort of summarized the whole thing, and what I'm going to share today is actually Poonam has already set the context, and I think 10 years back when all the stakeholders meeting and this group was just taking shape, and I think this was where all this question of having a larger picture of what exactly is the status of the RB in India, because the data we had before that were very scattered data, isolated from different corners of the country. We didn't have the big picture, but now I think 10 years down the line, with of course the study data and with the pulling of all, we now have a bigger picture. But I think before that also, with the support of the CAN kids and all the work which has been done to set the background for this study has been wonderful. So big thanks to CAN kids team, Poonam, and of course you, sir, for giving us the roadmap.
Go ahead, Seema. I think you're going to give us the big story, big picture.
I'll just share the results of the study and what Poonam had just mentioned that, way back, Dr. Nawar has given us the roadmap, the Vision 2020 roadmap for retinoblastoma, giving us a picture of where we want to see ourselves. Second. Just share my screen.
Yeah.
Yeah. Is my screen visible?
Yes, Seema. Make it full screen. Slow. Yeah. Perfect. That's good.
So this study took shape, I think, way back sometime in 2014 when the first stakeholders meet had happened in Delhi. And I think for this study to sort of take shape, it took probably another 4 to 5 years. And ultimately, in 2021, we could roll it out formally. And when the enrollment started, and in 2023, we completed the enrollment of the study. So the whole idea was that we need to have a bigger picture of what is the current status of retinoblastoma in India, where we stand, and what are the interventions we need to plan. And that was one of the major purpose of this study, which was held under the aegis of the INFOG. Dr. Hanover is the EI of this study, and I'm part of the study team. So we had scattered data about the outcome of retinoblastoma from India, and we know that the reported data from the south shows a pretty good outcome with just about 9% of the patient presenting with extraocular extension with more than 70% survival, even in the extraocular disease. But data from the other parts of the country are not that great looking, with very high incidence of extraocular disease at presentation and a very high incidence of treatment abandonment and non-compliance with the treatment. So just to get a clearer picture of where exactly we stand, this study was conceptualized with the idea of understanding the epidemiological and the clinical features of RV in India. And we had a standardized protocol, which as part of the study, all the participating centers were expected to follow. And one of the idea was also to evaluate the outcomes of all patients once we follow a standardized protocol. The secondary objective of this study was also to understand the reasons for very late presentation of the disease in many centers of the country, especially in the northern and the eastern part of the country, and also to understand and limit abandonment by doing intervention, which through the support of the candidates we have been doing as part of this study. So these are the collaborating centers which were spread out across the country. 20 centers had participated in this study, and 1,120 patients were enrolled as part of the study. And last year in September, we completed the enrollment process. The follow-up is still ongoing, and we had kept a follow-up period of about 3 years to know the outcome, but we have some data about the other parameters, including the epidemiological profile of RV patients in India. To give a context, we try to compare what we have found from this study with the data from the global retinoblastoma study, which is the largest study from across the world, with centers from across the world with the data pulled in, which gives a real world scenario of the current status of RV in the world, and also with the Asian data, which is published, which is basically a subset of the global RV data. So if you see, mostly the age at presentations are almost comparable with the global RB as well as the Asian data. But however, when we see the stage of presentation, in India, more than 25%, that's more than 1/4 of the patients still continue to present as an extraocular disease, and which is sort of, higher even from the global RB data, which was about 16.5%, the average data. Of course, there were geographic pockets where this figure was much more higher. So yes, this is one aspect where despite all the kind of improvements and all the support, we still are not doing very good, where 1/4 patients still had extraocular disease at presentation. And when we compare the data of the study patients and try to map them on the geographic map of India, if we see all the patients, the map on the left side is showing the data of all the patients, and we can see a fairly uniform distribution across most of the part of the country. However, when we just pull in the data of the extraocular patients, which were about 1/4 of all the study patients, there is a definite clustering of the patients in the northern and the eastern belt of the country and some in the central belt. So there seems to be a north-south kind of divide, even at presentation of the patients of heart. So at least this tells us where we need to drive our energy or put our energy in terms of awareness initiatives and the resources. Resources are always limited, and we need to know where we need to direct our resources. And with this kind of data, where we know that probably the awareness is so less that at presentations, most of the patients have advanced disease in this zone, we need to have more of activities directed toward increasing awareness about this disease in this belt of the country. The other aspect which we try to analyze from the initial data is what is the lag time for diagnosis and treatment, and where exactly is the lag? Are these the parents who are not able to diagnose, or even if they have noted something wrong in the eye, they have not taken a consult, which we have defined as the parental lag time. The second aspect was diagnosis lag time, where sometimes even if the family goes for a consult with a medical practitioner, the diagnosis is not made on time. So there is a delay at the level of the healthcare providers. And the last bit is the treatment lag time. Even after the diagnosis is made, sometimes there is a delay even in initiating the treatment, mainly because probably the facilities are not available nearby, and the patient has to travel to another center to get the treatment started. So on an average from this study, we are getting a lag time of about 4.2 months, which probably is comparable to some of the other studies which have come up from the India. But what was important or striking that out of this whole lag time, almost half of the lag time was at the level of the parent. So it again tells us that our awareness initiatives needs to be directed towards the community awareness, where we need to make the family, the parents aware about the early signs of the disease, so that they don't take the early signs of white reflex or a squint in a child seriously and go for an early consult. And also the advocacy initiatives for routine screening during contact with any healthcare provider, like as during the time of immunization, probably if it is possible to screen just a torchlight screening of the child's eye by the healthcare provider, many a times we can pick up the very early signs of the disease even before the parents notice it. We also try to look at what are the factors which could predict this increase in the lag time in the cohort of patients, because we found that the increased lag time is directly proportional to or directly correlating with the advanced stage of disease at presentation. So among the factors, all the factors, those which came out significant most significant were the literacy or the education level of the parents, especially the mother, the maternal education level. And also whether the first consult was taken with a specialist. By specialist, I mean an ophthalmologist or possibly a pediatrician, was vis-a-vis a non-specialist who could be a general practitioner or could be a practitioner of alternative medicine like homeopathy or Ayurvedic. And the other factors which also were significantly correlated with an increased lag time were the socioeconomic status, the distance of the residents of the family from the treating centers, which is again a reflection of the access to care. Age at pregnancy and other things like leukocoria versus non-leukocoria as the presenting symptom, possibly because the diagnosis is delayed if you do not have the typical symptoms at presentation. But the most important factors seem to be the education level of the parents, especially the mother, and the first consult by a non-specialist doctor. So if we see the data of the first consult, these are the three main groups of healthcare providers where the first contact has been made before the diagnosis was established. And as we can see from the data, almost 50%, when the pediatrician was the person where the first consult was taken, almost 50% of the time diagnosis was made. However, in 50% of the time, the diagnosis was missed also. Ophthalmologist, of course, we expect it to be better. It was better, but still there was a substantial proportion of patient where even when the child was seen first by an ophthalmologist, the diagnosis was only made at the subsequent visit, but not at the first visit. But what was alarming was that if a non-specialist is seeing the child, most of the time, majority of the time, the diagnosis was not made at the first contact, and it was only after several contacts that the diagnosis could be established. So we need to direct our awareness and training initiatives, not only towards the ophthalmologists, but also the other cadre of the healthcare workers, especially the healthcare workers like the traditional medicine practitioners, who are usually the local or the first level of contact at the village level or the rural areas. So they need to be part of this loop of the awareness and training initiatives. The other important factor which came out pretty striking from this study was the maternal education level. And here again, if we just distribute the patients according to the zone of the country, these are the zoning of the country as per the zonal councils. And we have clubbed the east and the northeast zones together because we had only one center from the northeast zone. And if we see the presentation of the disease according to the different zones of the country, we see that the majority of the patient or the maximum patients who had extraocular disease at presentation belong to the north or the east zone of the country, as compared to the south zone, where less than 3% of the patient presented with extraocular disease. This was at the first consult, as compared to 33% from the north zone and 41% from the east zone of the country. Now, if we see and try to correlate with the education level of the mothers, this is directly correlating with the maternal education level. In the south, where probably the literacy rates are pretty higher, with just about 12% of the maternal education level being illiterate or primary school or less than that, vis-a-vis again the north and the east, where almost half of the maternal education level status was less than primary school or illiterate. So again, there is a cause for directing the awareness initiative, because most of the time the mother is the caregiver. They are the one who should be made aware about the early signs and the symptoms of this disease, and so that we can diagnose these children early. As far as the facilities for imaging and UA is concerned, we are not doing it's pretty well. Like most of the time, 90% of the time, UA was done and an imaging was done before the treatment was initiated, which is as per the protocol. This is in contrary to the general impression that we tend to have that, the lack of GA facilities might not let the UA be done before the treatment is started. But of course, there is a scope of kind of taking care of those 10% also where it is not done. Genetics is another important aspect. And if we compare the genetic testing status of the patients of our study as compared to the global RB and the Asian data, most of the, like in both the global RB and the Asian data, almost 35 to 36% of the patient got a genetic testing done, which is now mandatory for as per the staging workup of the RB also. But in our study, only 6.2% of the patient had genetic studies done to establish the germline status of the patient. So I think there again, there is a scope of increasing awareness. Cost, of course, is an issue, but through CanKids now there is a facility of supporting the genetic testing also if there is a need for some selected cases. And I think we need to increase awareness at least about this facility so that more and more patients can avail of the services of this. The first-line treatment advice were as per protocol and almost in par with the Asian data, slightly different from the global RB data, but that also I think there is a geographical variation here. But what was most striking was that the initial results which we have, the one-year follow-up we have now of this study, because the follow-up is still ongoing, some of these patients are still continuing with the treatment, but the treatment abandonment seems to be 7.3% as of now, which is possibly the lowest reported in any study in India till now. So I think that's the power of the study, having a prospective study where you have more strict follow-up, better handholding of the families, as well as more support of treatment support for the patients. Also, it is possible to reduce the abandonment, and the previous reports of 30-40% abandonment, if we can bring it down to less than 10%, and to the range of 7.3% is something which probably one of the goal of the study, which seems to be achieved as of now. And again, as was expected, there was an inverse correlation of the abandonment with the education status, especially the maternal education status. And of course, the distance travel. So it again highlights that we need to have better access to care. Socioeconomic status was, of course, also was important and had an inverse correlation with treatment abandonment. But what was striking was that more than 50% of the patient, the abandonment was not at the initiation of the treatment, not at the they've come at the first time and they never came back for the treatment or did not even initiate the treatment. A major chunk did start with the treatment, but did abandon the treatment almost after 3 months, on an average after 3 months, which shows that there is probably need for even by the healthcare workers who are coming in contact with the family and the patients and are doing the treatment. Probably there is need for more counseling and making the family more aware about the importance of continuing with the treatment, importance of compliance, and probably a little better handholding might bring down this figure also. Bilateral patients, extraocular disease, where already the prognosis is poor, had in higher abandonment. This is possibly because of, once we talk to the family, explain them to the prognosis to them, and this also might affect whether they want to continue with the treatment. So just to conclude, 1/4 of the patient in this cohort presented with extraocular disease, and out of all the lag time, the most of the time, it seems to be, the delay seems to be at the level of the parents. For some reason, they are not able to either diagnose the disease early, or even if they are able to diagnose or note the symptoms, signs early in the child's side, they are probably not taking an early consult, thinking that it is something which is not so serious. So there is a need for increasing awareness among the community. And delayed recognition by the healthcare workers, especially the non-specialist, is something which we need to work on. And these are the things which are doable if we take the appropriate intervention. So if we have to diagnose this disease early, we can only improve the outcome if we diagnose the disease early. If 25% of the patients are coming at a stage where the disease is extraocular, whatever we do, we still can't kind of improve the outcome, at least for those cohort of patients. So we need to diagnose the disease early, and for that, probably community awareness should be the way to go. And we need to have some advocacy initiatives where at least a routine screening can be incorporated with the other healthcare intervention programs, like during the time of immunization, or at any other contact wherever a healthcare provider is coming in contact with a child or with the family. And the healthcare providers themselves need to be trained. They need to be made aware about the early signs and symptoms of the disease of RB so that we can diagnose them early. So these are all the partners from the 20 participants, participating centers, and I acknowledge the contribution of all the centers for making this study. So thank you very much.
Thank you very much, Seema. I think there are a couple of questions on the social media platforms. One is by Dr. R.K. Verma from Gaya. He says, why is this north-south divide? What is the reason and what do you propose to do about it? And he's also gone on to ask, was there any east-west discrepancy?
Yeah. So I think as we also try to find out why was this north-south divide. One, of course, we know that the population density itself is kind of, there is a difference between the two parts of the country that itself will increase the incidence of RB that happens every year in the two zones of the country. But I think it has also to do with the awareness levels and the access to care. Because most of these centers, the ocular oncology centers, we all know they all started down south initially, and now many centers are there down south, which are pretty well established and has been, providing services for the several years now. And so probably the awareness part is little more even among the population there, that there is a service option which is available. And since the literacy level and the socioeconomic standards are much higher in that part of the country, the awareness level even among the parents and the caregivers are a little more higher. So they are able to pick up the early signs, they are able to go for an early consult, and hence the disease is getting diagnosed at a very early stage. Compared to the northern and the eastern part of the country, where we are finding diseases or patients who are coming at extraocular stage for about 30 to 40%, compared to just about 3% in the southern. So I think that's one. And yes, we did find a difference between the eastern and the western zone of the country. Not too much, I would say, but there was about 5 to 10% difference in the stage at presentation between the eastern and western zone.
Yeah.
But again, saying that it's not that we have captured the data of all the patient. If we see the numbers which we have captured and the number which Poonam had shown, the estimated average number every year, we probably have captured the data of about 2/3 of the patients, what we expect to see in an year in India. So there is still a scope of capturing the other 1/3, and that will probably give a much better picture of the real scenario in India.
Yeah. One question by a pediatrician: Can kids advocate mandatory eye evaluation by pediatricians with the government of India? That's one question to Can Kids. I mean, Poonam can take that. And one more question to Seema that's come up is, was there any difference between the data that you have gathered from India in comparison to countries of other parts of the world with similar economic stature?
So if we just see the subset of the data from the global RB also, our data were somewhere probably in between the Asian data and the data from the African countries. So we are a shade better probably than what is the kind of stage of presentation in the African countries. But if we see the data from the other Asian countries, probably at least the average, if you compare from the other Asian countries, our presentation stage of extraocular disease is much.
Yes, indeed, we can. And I think that's a very good idea. We will take it up. I think our big advocacy pieces are one about the early detection and what can we do around that. Two, as you just mentioned, I think there's a lot of RB in UP, Bihar, in these areas, more populous anyway in terms of incidents. And I think we need to ramp up the awareness and the early detection messages, both at the primary and the next level stages. And then the third is, as we've just spoken to ophthalmologists and likewise the pediatricians, I think it's very important. This is a very good suggestion, and we would definitely like to take it up.
Yeah. Pediatrician herself has asked that question, and she has also gone on to say that, can we integrate it with immunization somehow?
Yes, this is correct. This is exactly what we are actually putting out. We're actually working with the RBSK programs and the other programs at the government, state government levels to say that, okay, can this be integrated at that stage itself? And I think we should be able to make headway, and I think we should be able to come back with some good news on that. I have to say that the study was very, very important because the rest of our studies tend to show that it is the delays with the healthcare provider. Here is a study which shows that there is more delay on the parental side. And therefore, I think it also allows us to advocate accordingly. And I think these are important key vital steps that we will take up. I think the focus on the north is important because we still see a lot of children with extraocular disease in the north. And I think a lot of it also, because I work on survivorship, more people in the South believe you will survive. So they show up early, they are there early for detection. The doctors are more easily accessible. But I think the RB centers in the North are strengthening. There's some amazing work going on in the North as well now. So I'm hopeful.
So one question from an oncologist. Dr. Venkateshwaran from Chennai. He's asking whether, apart from CanKids, are there any other government resources that can support children with cancer? And can anybody highlight? I know anybody from your team probably can answer that.
So no, I can tell you, and I had it on my deck. The Ayushman Bharat scheme, of course, has packages both for extraocular and intraocular RB. And so do other government schemes, the Prime Minister's Relief Fund, Rashtriya Arogya Nidhi. So there's a lot of government support everywhere. So in fact, of the centers in our Fight RB India network, I think more than 50% of them are Ayushman Bharat hospitals as well. So that means that children will get support from the government. And a big piece that NGOs do is actually make sure that you can access, and we facilitate families to be able to access the scheme. In fact, that is why we provide the social worker to the hospitals so that the social worker can actually work with the doctor and the families to get the access to the government schemes. And I think this is very, very important to get the support. What was the second question from him? One was on the government access.
Can somebody highlight about the resources that are available to support these children apart from CanKids themselves?
So as I said, I think there's a lot of government support, and there are other NGOs as well who are supporting childhood cancer. And we have in the resource directory that I mentioned, it covers many of these resources that are available. Perfect.
So thank you, CanKids team, Poonam, Seema, of course. So we go to the next part of it, which is a clinical lecture on retinoblastoma itself, an overview. And I'm going to do that. I'm going to share my screen and start.
Thank you, sir. Thank you.
Thank you so much. Right. So I've titled it Retinoblastoma, they live and see because they are living and they're seeing as well. Visual prognosis has tremendously improved in retinoblastoma. Eye salvage is obviously possible in a majority of patients, and 98% of them actually live on. Why should we know about retinoblastoma? There are many reasons why one should know about retinoblastoma, because it is the most common intraocular malignancy in children. Of course, it is a deadly tumor with potential for up to 50% death if it is not detected on time, not treated appropriately. And also it present mostly to an ophthalmologist or perhaps to a pediatrician first, because the symptoms or signs are glaring. White reflex is glaring. Parents, grandparents especially detect it. Squint is a symptom which obviously is very evident. Unlike an abdominal malignancy or something that happens in the brain, retinoblastoma is very evident externally, and these children are actually staring at you begging for a diagnosis. All you need to do is look at those signs and diagnose them early. And most importantly, it is completely curable if it is detected early. And that's the reward that we have. If retinoblastoma is detected even in group E situation, it is completely curable in terms of life salvage, eye salvage perhaps in a majority of patients, and vision may not be in group E, but then still we are able to save life and the eye. This is the world retinoblastoma map. Retinoblastoma still happens in India quite a bit. That's because of the high population that we have. Otherwise, it's fairly well distributed all over the world. And this is the data that we have: 5,000 to 6,000 new patients of retinoblastoma every year in the world, of which about 1,500 to 2,000 are estimated to be happening in India. We really don't have the exact information. New retinoblastoma referrals to major referral centers in 2017 was about 600. I think now it has risen dramatically, perhaps to about 1,000 to 1,200 patients are referred to retinoblastoma referral centers or treatment centers. That's because we have more of them now currently all across the country. As Poonam showed, there's a directory of retinoblastoma treatment centers. About 70% of children earlier, prior to 2017, were treated in primary or secondary levels of healthcare, where only enucleation was the treatment that was available. That is no longer so. We have the facilities for management of retinoblastoma available across the country, and we are able to treat them well. Very important, estimated 30 to 50% mortality without protocol-based management. That means if you simply enucleate and leave these children alone, then 30 to 50% succumb to retinoblastoma because of metastasis, local tumor recurrence, etc. Whereas if you were to follow protocol-based management, then mortality can be reduced to less than 5%. Evolution in management of retinoblastoma is very, very striking. You can see that in 1900s, about 120 years ago, we had 98% mortality. Currently, we have more than 98% survival. That kind of turnaround hasn't happened in any other malignancy except retinoblastoma, mainly because it is easily diagnosable and easily treatable. Going on to clinical manifestations. This is perhaps is common to most of the world, actually, especially in developing countries. Leukocoria is the primary manifestation because children are detected quite late, and leukocoria happens in about 1/3 to 2/3 of the eye, or more than that, is filled with a tumor, depending on the location of the tumor. If the tumor were to be peripheral, say nasal peripheral, then a large tumor has to be there to manifest leukocoria. Whereas if it's a macular tumor, obviously leukocoria is evident quite early, but it is the symptom in about 50% of patients. It is also the most common presenting sign. This is how children with leukocoria present, bilateral or unilateral. It's a very striking sign. It is a very striking symptom. No ophthalmologist or a pediatrician or no parent or a grandparent can easily miss it. Squint can sometimes be missed because squint can be intermittent, and squint can also be because of other reasons. So squint can sometimes be missed, and that is one of the reasons why retinoblastoma can be missed. In children with squint, it doesn't cause a sense of emergency that patient or a child should be brought to an ophthalmologist, whereas a white reflex seems abnormal. Squint happens in about 25% of children as one of the signs or symptoms. Depending on whether the tumor is macular, paramacular, or what age would the tumor affect vision, squint can be esotropia or exotropia. Majority of children with squint present with esotropia, with retinoblastoma. Other symptoms are, of course, decreased vision in an older child. That could be a symptom, and also redness in the eye. Whenever there is redness in the eye or swelling in the eye, conjunctival congestion, chemosis, etc., then there's a high chance of having extraocular extension. So this is already late when the child manifests with a red eye. That means that tumor is necrotic, because of which there is sterile inflammation that causes this red eye. Fortunately, as Seema has pointed out, this has become quite rare, although there is a north-south divide, orbital retinoblastoma, because this is one type of retinoblastoma, one manifestation of retinoblastoma, where if it is not treated with multimodal therapy, then there is more than 50% mortality. This is the spectrum of retinoblastoma in one slide. Macular or a posterior polar tumor that happens in younger children. In fact, there is a way retinoblastoma generally develops in the posterior pole or macular fovea in a young child. And as the child ages, retinoblastoma becomes more and more peripheral. But when it fills the eye, of course, the epicenter cannot easily be judged. Leukocoria is the next manifestation, extraocular extension, and finally, a very rare form currently, a fungating tumor. We should also know about the masquerades of retinoblastoma. Sometimes it can present simulating orbital cellulitis. Nobody can deny that this child has preseptal cellulitis, orbital cellulitis, but it may not be infective. Although this manifestation is rare, whenever a child manifests to an ophthalmologist with preseptal cellulitis or orbital cellulitis, the child may not be cooperative for a fundus evaluation. You may not be able to give general anesthesia to this child for a EUA on the same day or in a few days following this manifestation, but definitely you can do a very quick ultrasound B scan to see if there is an underlying retinoblastoma. This is for ophthalmologists. So whenever a child manifests with preseptal or orbital cellulitis, don't forget to do an ultrasound B scan. The second manifestation would be uveitis. In a slightly older child, uveitis is a masquerade of retinoblastoma. You can see this child has hypopyon uveitis and the eye is absolutely white. So we say that if a child has a white eye hypopyon, then that could be a diffuse infiltrative retinoblastoma. Another differential diagnosis would, of course, be medulloepithelioma in this child, but then there the hypopyon would be in the form of translucent balls, whereas in retinoblastoma, it's more often a flat white hypopyon. It could have a peaking, etc., depending on the configuration of hypopyon, but still a white eye hypopyon is suggestive of retinoblastoma. Some of these children may manifest simulating congenital glaucoma. Of course, this child has glaucoma. That is the reason why the child has a large cornea or megalocornea or ophthalmus, but then that is secondary glaucoma because of retinoblastoma. It's not primary congenital glaucoma. And if the cornea were to be hazy or opaque because of long-standing elevation of intraocular pressure, then obviously this yellowish, orangish reflex would not be seen at all, and these children can be missed. They can actually be operated for trabeculotomy, trabeculectomy. Unless you have done a good B scan and detected the presence of retinoblastoma, they can undergo an intraocular surgery. Unfortunately, that will spread the tumor outside the eye. Thiazical eye. Now, thiazical eye in retinoblastoma is mainly because the tumor would undergo spontaneous necrosis. It's a round cell tumor, and any round cell tumor needs a lot of blood supply. It grows rapidly, and at some point in time, in a rapidly growing tumor, there is ischemia, and as a response to that, there will be intraocular inflammation, sterile intraocular inflammation, severe uveitis, because of which there is ciliary body shutdown. And finally, eye goes into atrophy and phthisis very quietly without anybody realizing it. Some of these may be associated with a history of wake trauma. So parents give that history, and ophthalmologists and pediatricians think that the eye has gone into phthisis following kind of a trauma, blunt injury, etc. So this can be missed. Now, even on CT scan, this is often confused to be a case of, say, dystrophic calcification within a thiazical eye. But the way to differentiate is this: if this is the eye on CT scan, if the calcification is in the coats of the eye, that means choroid and sclera, then that is how dystrophic calcification clearly presents. But if the calcification is within the vitreous cavity, that is intraocular calcification within the vitreous cavity, that is more suggestive of retinoblastoma. So you can actually differentiate on CT scan by the location of calcium itself. In dystrophic calcification, there could be just specks of calcification if it is in the vitreous cavity, whereas in retinoblastoma, it's large chunks of calcification. In any case, an atrophic eye or a thiazical eye in a child should not be subjected to evisceration at all. If at all you want to do something for cosmetic purposes and the diagnosis is not clear, you should follow the protocol and enucleate this eye with long optic nerve stump and let the pathologist tell you whether there is a hidden or an occult retinoblastoma. Next would be hyphema. This child has all the signs of trauma. Child has a lid abrasion, child has a small skin cut, and the child has full chamber hyphema. There was indeed a trauma. This child suffered a trauma with a tree branch, but then there was a retinoblastoma already. So the predisposed eye bleeding happens more readily, and this child has a full chamber hyphema with which the child came, but the underlying cause is retinoblastoma. Ophthalmologist did a trabeculectomy with hyphema drain in this child, and you can see that there is extraocular extension 6 months later. Not just that, there is intracranial extension as well, regional lymph node metastasis, and we could not save this child. So any child who presents with hyphema, again, before you evacuate hyphema, just do a simple B scan that will tell you whether there is an underlying tumor or not. If there is none, you can go ahead with whatever you have to do for hyphema. But if there is any suspicion at all that there could be an underlying tumor, you should do imaging before you conclude that there is no tumor. This was a child who presented again with a history of trauma to a retina specialist this time, and the child has vitreous hemorrhage. But you can note that there is dilated supratemporal arcade. In a classic case of traumatic vitreous hemorrhage, there should be no vascular dilatation. Here there was. So this child underwent vitrectomy by this retina specialist, and he has actually seen the rest of the fundus. It was supposed to be normal. This is how it was at the end of vitrectomy. But a few weeks later, the child had rhegmatogenous retinal detachment. He went ahead and did a buccal. And now on top of the buccal, you see grayish area. Now posterior to the buccal has also shown some whitish opacity. So this is progressing from periphery to center. And in an older child, you should suspect diffuse infiltrative retinoblastoma. And this was indeed a case of diffuse infiltrative retinoblastoma presenting with vitreous hemorrhage. You can see that the retina is not grossly thickened. You don't see the kind of an elevated large tumor here. You only see diffuse thickening of the retina, perhaps twice or thrice more than the normal thickness of the retina. There is no calcified mass. So this can easily be missed. Diffuse infiltrative retinoblastoma in an older child can simulate many other conditions, can easily be missed. So you should be very careful in an atypical clinical presentation. This was this diffuse infiltrative retinoblastoma. So these are the masquerades that I had shown, but more importantly, all these masquerades are more common in older children. So any older child, 5, 6, 7-year-old who presents with any of these simulating conditions, you should keep retinoblastoma as one of the differential diagnoses. Now, what are the intraocular tumor types? In retinoblastoma, we have endophytic, exophytic, or diffuse infiltrative.
Data from the global RT also, our data were somewhere probably in between the Asian data and the data from the African countries. So we are a shade better probably than what is I will say your presentation in the African countries. But
we have something else that is coming up. I think, Sunil, can you mute?
If you compare to other Asian countries, our presentation stage of extraocular disease is.
Yes, indeed, we can. And I think that's a very good idea.
Sunil, there is a webinar playing at the back.
I think our big advocacy pieces are one about the early detection and what can we do around that.
Poonam ma'am, yeah, I think your audio is on.
I think there's a lot of our.
Okay. So I'll go ahead with intraocular.
And I think we need to wrap up.
Prolika, can you ask Sunil to be
at the primary and the next.
Yes, sure, I'll do that.
Yeah.
Yes, sir.
Ophthalmologists.
Sunil, can you be online, please? And help?
I'm there, sir.
Yeah. So this is
suggestion, and we would definitely like to.
Can I go ahead?
Ji, sir.
Okay. Now, intraocular tumor types in retinoblastoma, endophytic is more common. Endophytic is when the tumor grows into the vitreous cavity like this. Exophytic, where there is exudative retinal detachment. In endophytic tumor, there is classically vitreous seeds. In exophytic, there is classical subretinal seeds. And diffuse infiltrative, as I showed in the child with vitreous hemorrhage, the tumor glows like a plaque into the retina and there is diffuse thickening of the retina. These are the ones which generally masquerade. The mixed configuration where there's a bit of endophytic, bit of exophytic, and bit of diffuse infiltrative is most common clinical type. Now about the way this retinoblastoma manifests in India, majority of children present with either group D or E retinoblastoma, that's how it manifests, and that is the reason why sometimes it is difficult to treat and give the kind of prognosis that the West has. But the diagnosis in retinoblastoma is very simple. Indirect ophthalmoscopy is the most important diagnostic tool. All ophthalmologists have access to indirect ophthalmoscopy, and you simply need to anesthetize the child and see the child under anesthesia. Unless the child is cooperative, or you can hold the child down and look at the fundus with indirect ophthalmoscopy. Whatever, but then indirect ophthalmoscopy is the diagnostic tool. You see the tumor, you diagnose it, as simple as that. Ultrasound B scan can be performed in a confounding clinical situation to see if there is any intraocular calcification. USG also helps you to measure the diameter of the tumor and also the height of the tumor that can be used for judging the response over a period of time. What is most important is the role of MRI. MRI helps you in many ways. MRI can currently, the high resolution 3 Tesla plus MRI can tell you whether there is any choroidal invasion or not. It can tell you whether there is an optic nerve invasion. It can also tell you the extent of optic nerve invasion, whether the optic nerve sheath is involved or not, whether there is any meningeal involvement or not. There is also a possibility of extraocular extension that can also be detected on MRI. So MRI is very important to stage the disease at primary presentation. So we routinely do MRI in all children with unilateral and bilateral retinoblastoma currently to stage the disease. That really helps. Another role of MRI is to see if the child has pinealoblastoma. Even in unilateral multifocal tumors, which is genetic, there can be pinealoblastoma, and of course in bilateral retinoblastoma there could be pinealoblastoma, and it is mandatory that we should rule that out upfront. Recent advances in diagnosis was just a supportive role would be the use of OCT for small tumors, and then there is a role for liquid biopsy as well, and that could be used actually in confounding clinical situations, just an aqueous tap to see if there is any molecular diagnostic possibility to rule out retinoblastoma, rule in retinoblastoma in a confounding clinical situation. What are the most common simulating pseudoretinoblastomas or simulating clinical conditions? Depending on which country you practice, these are the 5 most common situations. The order could be different depending on your clinical or geographic situation, but Coats disease, PHPV, toxocariasis, astrocytic hamartoma, and medulloepithelioma are the differential diagnosis for retinoblastoma. In Coats disease, there is exudative retinal detachment, and the reflex that you see is golden yellow. This is called xanthochoria, as opposed to leukochoria in retinoblastoma, where there is white reflex or pale yellow reflex. In Coats disease, it's this golden yellow reflex that's very, very striking. This is xanthochoria, whereas this is leukochoria. So the quality of the white reflex or the reflex that you get is absolutely different. That is how you diagnose Coats disease. Beyond that, when you look at the fundus, you find this peripheral retinal telangiectasia, which is absent in retinoblastoma, and also this segmental dilatation of the blood vessel, which is absent in retinoblastoma. In retinoblastoma, you find uniform dilatation of the blood vessel, whereas the segmental dilatation is typical of Coats disease, apart from peripheral retinal telangiectasia. In the posterior pole in retinoblastoma, you find a tumor, of course, and in Coats disease, you find this refractile clump of exudation, which can actually look like a tumor on a cursory evaluation. On B scan in retinoblastoma, you find a tumor, whereas in Coats disease, you simply find exudative retinal detachment with thickened retina. And if you still have any doubt at all, then you can use a RETCAM to do this FFA, and that can support your diagnosis. In PHPV, the child will have relative microphthalmos. It may not be by measurement defined as microphthalmos, but the corneal diameter may be 1 millimeter less than the other eye or 1.5 millimeter less than the other eye. More importantly, the child will have prominent ciliary processes and also posterior polar cataract. That is very, very striking, and that's how you diagnose PHPV, whereas in retinoblastoma, you have none of that. Ultrasound, of course, will help you further confirm the diagnosis. In toxocariasis, there could be anterior segment inflammation, because of which there could be synechiae, cataract, whereas in retinoblastoma, anterior segment inflammation is rare. But when you look at the fundus, in a peripheral toxocaria granuloma, you find desmoplastic activity. This retinal fold or traction bands can be seen, whereas in retinoblastoma, you don't find a traction band at all generally. In a posterior polar toxocariasis, again, you find desmoplastic activity, because of which you get this dragged disc appearance, where the blood vessels, because of fibroblastic activity and the retina surrounding it, would be dragged towards the lesion or towards the optic disc, and the optic disc seems to be dragged towards the lesion. So this is the typical drag disc appearance in toxocariasis, whereas in retinoblastoma, you find a quite white tumor. In obviously, this is seen in tuberous sclerosis, astrocytoma of the retina. You can see there are two variants. One is endophytic and the other one is exophytic, and there are other variants are non-calcified astrocytoma and a calcified astrocytoma. So this could sometimes lead to confusion about retinoblastoma, but you see the kind of calcification here. This is very clear pearly appearance, where the peripheral rim of this particular globules is calcified. It is not intensely or densely calcified. You can see that in astrocytoma as opposed to calcification retinoblastoma, which is quite dense. This is a close-up view of astrocytoma, which can simulate retinoblastoma. The next differential diagnosis would be medulloepithelioma of the ciliary body. Medulloepithelioma is an embryonal tumor. So zonules fail to develop in that area, resulting in what is called zonular coloboma or a lens coloboma, and adjacent to it would be the tumor. Right? That's the ciliary body tumor, that is the zonular coloboma, because of which lens appears incomplete. Whereas in retinoblastoma, this doesn't happen. So whenever there is a zonular coloboma or what appears to be lens coloboma and a peripheral tumor, you suspect medulloepithelioma and not retinoblastoma. And because of the hyaline cartilage within the lesion, it can appear very dense. It can look as if there is an intralesional calcification. There could also be intralesional calcification in teratoid variant of medulloepithelioma, and that could add to diagnostic confusion if the media is not clear. So medulloepithelioma is definitely a differential diagnosis for retinoblastoma. Right. So going on to classification. In classification, for any tumor for that matter, there are two ways of doing it. One is staging and the other one is grouping. Well, for any tumor classification, you have to follow the logical sequence of manifestation of a particular tumor. That means that it should be flowing, it should be simple and easy to recollect. You should not have a complicated classification where you cannot simply remember that classification and you have to refer to your notes or a chart on the wall to classify it. It should be applicable to current therapeutic modalities. After all, why do you need to classify something? You need to classify something to prognosticate a given condition, isn't it? So when you want to prognosticate, it should be applicable to current therapies. If it is not applicable to current therapies, then there is absolutely asynchronous kind of a classification. It doesn't kind of match with the prognosis that you want to discuss with a family. There are two ways to classify. One is tumor staging, where survival is the outcome. Tumor grouping, where the eye salvage is the outcome. In retinoblastoma, we have both tumor staging as well as tumor grouping. Second. Yeah, this is the International Retinoblastoma Staging System, IRSS, described initially by Shantida, where stage 0 is no enucleation has been performed. That means that one or both eyes have intraocular disease and they have been salvaged by conservative therapy alone. So no enucleation being performed is stage 0. Stage 1 is enucleation has been performed and the tumor is completely resected. And who's going to tell you that the tumor is completely resected? Of course, the pathologist. So unless you have a histopathology report or a good histopathology report, you cannot stage it accurately. So stage 1 is tumor has been completely resected. There is no residual tumor, optic nerve transaction, and is free of tumor. Stage 2 is enucleation with microscopic residual tumor. Again, a pathologist has to tell you whether there is microscopic residual tumor. Any amount of residual tumor, it means full thickness scleral invasion or involvement of the optic nerve transaction, is considered microscopic residual tumor. Full thickness scleral involvement, because of the possibility of microscopic seeding of the orbit, you consider it as a possible microscopic residual, whereas if the optic nerve transaction is involved or if there are skip lesions of the optic nerve sheath up to the cut end of the optic nerve, then it is definitely considered a microscopic residual. Stage 3 is regional extension, overt orbital disease, or regional lymph node extension. So stage 3A is orbital retinoblastoma, stage 3B is regional lymph node extension. Stage 4 is metastatic disease, hematogenous metastasis, single or multiple lesions, or CNS extension. 4B, prechiasmatic CNS mass itself, or leptomeningeal disease. So if you look at it, leptomeningeal disease is the last, that means stage 4B3, which has the worst prognosis. If a child has leptomeningeal disease already, then there is hardly any survivor. Until stage 3, there is excellent prognosis. Even in orbital retinoblastoma, we have about 90 to 95% life salvage, whereas beyond that, it suddenly drops. So the prognosis suddenly drops after stage 3, and that's the watershed zone that we consider. So we should aim to diagnose retinoblastoma before the child reaches stage 3. In international grouping of intraocular retinoblastoma, which has two variants, one is the Shields classification, Philadelphia and the Los Angeles, but irrespective of what you follow, the grossly the same. In group A, there is a small tumor, small, less than 3 millimeter. Group B, B for bigger, is a tumor which is more than 3 millimeter, macular in location, less than 3 millimeter from the fovea, or less than or equal to 1.5 millimeter from the optic nerve. So that is group B, or any tumor with subretinal fluid. So group B is a bigger tumor, closer to the macula, closer to the optic disc, and with subretinal fluid. Group C is a little larger tumor. If it is exophytic, it would have subretinal seeds. So focal subretinal seeds, that means subretinal seeds close to the tumor in a exophytic retinoblastoma, would be group C. Focal vitreous seeds that would be close to the tumor in an endophytic retinoblastoma would also be group C. So C is for confined or contained subretinal or vitreous seeds. D is for diffuse. Group D is for diffuse vitreous seeds or diffuse subretinal seeds. E is potentially enucleable eye. Any eye with more than 50% of the volume of the eye filled with a tumor, any eye with neovascular glaucoma, neovascularization of the iris, blood in the anterior chamber, blood in the vitreous, invasion or infiltration of the any of the anterior segment structures, or involvement of the choroid or optic nerve on, say, MRI, would make it group E retinoblastoma. This is international grouping of intraocular retinoblastoma. What is new is this. The new is the TNM classification. TNM is a very well-known classification. It is used for most of the malignancies. It is tumor node metastasis classification. But then now we have a new alphabet that is added to it, that is H, that is heritability. No other malignancy has this TNM H classification except for retinoblastoma. So genetics has been brought to the forefront by TNM H classification, giving due weightage to the heritability of the disease. So probably we should in future be looking at this very carefully and doing genetic tests for a majority of our children so that they can be appropriately prognosticated and guided further. Going on to the management of retinoblastoma. Now, we all realize that retinoblastoma is a success story. From 95 to 98% mortality, now we have 98% survival, essentially because of early diagnosis and improved methods of treatment. Now, whenever you talk about management of any malignancy, you talk about life salvage first. That is your primary goal. Similarly, in retinoblastoma, life salvage is the primary goal. Organ or eye salvage is the secondary goal. So if life salvage is possible, then you want to optimize eye salvage. If eye salvage is possible, then you want to optimize residual vision. You never reverse the order. So life comes first, followed by eye salvage, followed by vision salvage. Only when eye salvage is possible, you want to use such therapeutic modalities that would optimize residual vision. We have many treatment modalities for retinoblastoma, which could be grouped as focal, local, and systemic, and we'll discuss many of them. Now, whenever there is a small tumor, child has a small tumor, we are very sure that a small tumor, a group A or a group B or even a group C tumor will not have any implication on life salvage, and eye also can be reliably saved. That means that, well, there is a good chance of life salvage, eye can be saved. What is next? We have to optimize vision. So focal therapy, we have to provide optimal vision by producing minimal scarring and minimal collateral damage. That is the aim of providing optimal focal therapy. Cryotherapy is one form of focal therapy. Cryotherapy is highly reliable. It has been used for decades. It has more than 90% success. The child will need 1 to 3 sessions of cryotherapy to have complete resolution of the tumor. But the problem with cryotherapy is that the size of the tumor is much smaller than the scar that ultimately results. That's because cryotherapy is very heavy. It is triple freeze thaw cryotherapy. That means you freeze the tumor thrice and spontaneously let it thaw thrice. This is a tumor that has been elevated on the top of a 3 millimeter wide cryoprobe. That is, the tumor has to be centered on the tip of the cryoprobe. Then you freeze it completely. When you freeze it, not just the tumor, but a cup of little bit of vitreous, which is anterior to the tumor, also should be included in the eye spall. So that's a very heavy cryotherapy, and that results in a large scar, as you've seen here. So cryo is very good. It has high success rate. But if it's the only seeing eye of a child and the child has a tumor which is slightly anterior to the equator on the temporal side, I may not use cryotherapy as my primary modality, because such heavy cryo anywhere close to the macula would or may have a possibility of producing, say, epiretinal membrane or traction on the macula. And also there is a risk of rhegmatogenous retinal detachment because of atrophic cold. So cryo is very good for a peripheral tumor, but we may not always use it. What about photocoagulation? Photocoagulation used to be a standard modality of managing small tumors like this, 2.5, 3 millimeter tumors. They would be animized. That means that the blood supply to the tumor would be cut off by lasering around a small tumor. 2 rows of large diameter laser burns around the tumor, confluent laser burns, would take care of this tumor by cutting off its blood supply. So what does it do? It produces a larger scar than the tumor that you began with. That is the tumor that you began with, and now you have such a large scar, and also on top of that, the blood vessel that passes through that area gets blocked. So you produce microvascular occlusion and consequently visual field defect as well. If you were to laser on top of the lesion, you risk ILM rupture and production of vitreous seeds. And also, if you are doing laser while the child is on chemotherapy, because the vascular occlusion that it produces, it reduces chemotherapy uptake as well. So laser therapy has many disadvantages. So we no longer do photocoagulation, but we do use the laser, semiconductor diode laser, and we gently heat the tumor to about 45 to 60 degrees centigrade to produce tumor cell apoptosis. This is called transpupillary thermotherapy, or called TTT. Unlike photocoagulation, where we treat around the tumor, in TTT we treat on top of the tumor, right on top of the tumor. So the scar that is produced is generally not going to be larger than the tumor that you started off with. And also the blood vessels that pass through that area remain classically patent. TTT does not cause vascular occlusion. You can see a small tumor here that has also shown a very nice response, and the small blood vessel that is passing through it obliquely is also patent. It does not cause desmoplastic activity unless you do very heavy TTT, probably by underestimating the effect of this laser on the retina and the surrounding structures. So unless you do that, there is hardly any desmoplastic activity or fibrosis or traction or distortion of the macula or epiretinal membrane formation that you would induce. So it's a very quite nice treatment, and this is the current standard of care. And how do you reach the periphery with the TTT? Of course you can, because you use indirect ophthalmoscope delivery system where you use 1300 micron. That is a spot size. Spot size is larger than almost as large as the size of the optic disc. That large it is, so you can very quickly treat the entire tumor because it's a large spot size, and you can reach right up to the aura because it is indirect ophthalmoscope delivery system. We also have operating microscope delivery system, slit lamp delivery system with TTT, but not really for retinoblastoma. In retinoblastoma, we have to use an indirect ophthalmoscope delivery system to appropriately treat the tumor. That's the close-up view of the same tumor. You can see how classically the blood vessel that is passing through the tumor is patent. Now, what is new in TTT is the use of synergistic effect of indocyanine green along with TTT. This is a photodynamic effect. When we inject indocyanine green, the tumor takes up more of laser. It's a synergistic effect, and because of which a tumor that has recurred over a amelanotic scar such as this, otherwise it would have been difficult for us to treat this with TTT. With photodynamic effect of ICG added on, this tumor went away with 2 or 3 sessions of TTT. So basically this is useful specifically for tumors which are on the mound of a calcium with a amelanotic background, or for tumors which have recurred following say prior regressed tumor, say on overlying a regressed scar, or in tumors which are not responding adequately to standard TTT for about 6 or 8 sessions. That is when we bring in ICG enhanced TTT. Now, in our own study, we found that ICG enhanced TTT has about 80% regression of refractory tumors or tumors on top of a scar. So the conclusion for focal therapy is that less is more. That means you should aim to produce minimal scarring, minimal collateral damage. TTT is the treatment of choice. Photodynamic TTT is good for tumors on a non-pigmented scar or for refractory tumors. Now going on to local therapy. In local therapy, the challenge is optimization of eye and vision salvage with minimal scarring, of course, and minimal collateral damage, with an aim to provide eye and vision salvage. And one of the popular therapeutic modalities is plaque brachytherapy. It is not new at all. It's been used for several decades already. 4,000 to 4,500 centigrade is used for the tumor apex. Excellent success. 90% is the success rate with plaque brachytherapy in retinoblastoma when it is used as primary therapy. When it is used as secondary therapy for failed cases already, then the success may drop to about 60 to 80%. In primary tumors, of course, it works beautifully well, but we don't generally use it because the scar that is produced after brachytherapy is not going to be smaller than the tumor itself. Although clinically visible scar may be small, the collateral damage to the retina would definitely be there. Recent advance with plaque brachytherapy is that design itself with a notch plaque, we can reach right up to the optic nerve. The surgery for plaque is very simple and straightforward. I'll skip the video, but you can use plaque brachytherapy very usefully for tumors which are in the juxtapapillary location where chemotherapy may not be possible because of some systemic issue. So this is one such example where plaque brachytherapy has been used. This is a recurrent tumor following chemotherapy where plaque has been used. Although you find a stable scar here, a small stable scar, much smaller than the tumor that you began with, if you look at it carefully, you can see that there is vascular occlusion, and you can see that this entire area where the tumor was, the retina is unhealthy. Retina is atrophic, retina has vascular occlusion, and there is RP atrophy. So this retina is not good to see so much. So plaque brachytherapy need not be the primary treatment unless chemotherapy is contraindicated for some systemic indications, but it's a useful technique for tumors which are residual following chemotherapy or for tumors which are recurrent. Especially in peripheral tumors, if they're recurrent, plaque could be a very, very useful resource for you to utilize. So plaque brachytherapy has very specific indications. Of course, this Indian plate plaque is new, and we also have a retinoblastoma plaque, which is a 12 millimeter, a smaller plaque, which could have minimal collateral damage, and that could be used in children with retinoblastoma. External beam radiation is no longer used. External beam radiation is not so effective. It has about only 40 to 50% success, but it produces a lot of complications: ocular surface problems, radiation cataract, radiation retinopathy, radiation optic neuropathy, phthisis bulbi because of ciliary body shutdown, orbital and hemifacial growth retardation, are all the complications of radiation. And the most important complication is second malignant neoplasm. Radiation increases the risk of second malignant neoplasm to 35% as opposed to 6% if radiation were not to be given in a situation where there is heritable retinoblastoma in a younger child. So specifically in children who are less than 1 year of age, and if they have heritable tumor, then they have at least a 1/3 chance of developing a second malignant neoplasm such as osteosarcoma if we were to give radiation. So radiation is no longer used as primary therapy for the management of retinoblastoma. Next, we go on to chemotherapy. This was a game changer. November 1996, Archives of Ophthalmology, currently JAMA Ophthalmology, produced a series of articles. In fact, there were 4 articles on a new modality of management, then chemotherapy for retinoblastoma from 4 different centers, 3 in the United States and 1 in the United Kingdom. All 4 groups concurrently working on this new modality, and all these 4 articles were published in the same issue of JAMA Ophthalmology. Chemotherapy is like going back in time because you reduce the size of the tumor. That is how it's very useful, because the scar that is produced is going to be much smaller than the tumor that you began with. We started off with standard intravenous chemotherapy. Now we have all these forms of chemotherapy, which I'll discuss very soon. From standard chemotherapy, we have gone on to high dose. Now we have intraarterial, intravitreal, intracameral, etc. Coming back to intravenous chemotherapy or IVC, the way we started off with, it's a method of reducing tumor volume to allow for more focused and less damaging therapeutic measures. Like going back in time, it was called chemo reduction because that is the effect that you produce on the tumor. Classically uses carboplatin, etoposide, and vincristine, 3 to 4 weekly injections, 6 cycles, and it is mandatory. I stress it is mandatory to perform examination and anesthesia before each cycle by an ophthalmologist trained in ocular oncology to look at the response. It is not a treatment that is to be solely done by an oncologist. You cannot give chemotherapy without looking at the tumor response. It is very important. You cannot assess tumor response by an MRI scan or an ultrasound B scan. You have to look at the tumor, you have to measure it, you have to take a good wide angle fundus photograph or do fundus diagrams to assess the response before each cycle of chemotherapy. Also to see if there are any complications already. And more important, with each cycle of chemotherapy, you have to augment the response by providing focal therapy. There are 2 focal therapies that are done with chemotherapy. One is chemocryotherapy, where we freeze the peripheral retina with single one spot gentle cryotherapy, generally on the nasal periphery. This breaks the blood retinal barrier. This increases intravitreal concentration of chemotherapeutic agents by several times. This is very useful. The second focal therapy that we do is transpupillary thermotherapy along with chemotherapy, that we start off generally at the end of 3 cycles of chemotherapy. From the 4th cycle onwards, we start doing transpupillary thermotherapy, except if the tumor were to be very close to the optic disc or very close to fovea, where there could be visual implications because of TTT, where we withhold TTT until towards the end. Otherwise, TTT is started off with the 4th cycle. And whenever we do TTT, there is a higher chemotherapy uptake by the tumor. That's called chemothermotherapy or thermochemotherapy, depending on the sequence, whether you have done TTT first and given chemo, or if you have given chemo and have done TTT first, it's called chemothermotherapy or thermochemotherapy, both of which help in chemotherapy uptake by the tumor. So again, stressing that chemotherapy is not totally done by an oncologist. It has to be in partnership with an ophthalmologist trained in ocular oncology, because examination and anesthesia has to be done with each cycle of chemotherapy for assessment of the response of the tumor to chemotherapy and also to provide focal therapy. Now, how does chemotherapy work? Chemotherapy starts reducing the size of the tumor. So this was the tumor. This is one more tumor here. You can see how small the scar has become, right? So macular fovea is quite healthy. This patient can see fairly well. It reduces the size of the tumor. That's how chemotherapy works. The second principle in chemotherapy is that the tumor always hangs on to its source of blood supply and regresses away from macular fovea. Like for a posterior polar tumor, the blood supply is generally from one of the arcades, and the tumor would involve the macular fovea. Now, this particular tumor has the supratemporal arcade as its source of blood supply, correct? And it is impinging on the fovea at initial manifestation. After one cycle of chemotherapy, you can see that it has left the fovea partly and it has moved towards its source of blood supply, that is supratemporal arcade. So it just hangs on to its source of blood supply till towards the end. And at the end of 6 cycles of chemotherapy, perfectly healthy fovea, and the tumor is away from it, further away from it. See how ahead of it has moved, right? Thus maximizing visual potential. So tumor always hangs on to its blood supply and clears the fovea macula very early in the course of chemotherapy. One more example, how this fovea macula was not even visible at the initial manifestation, and at the end of treatment you find a fairly healthy fovea there with reasonably good vision. So that's how chemotherapy works. The next modality is, of course, retinal detachment. Exudative retinal detachment subsides very rapidly, thus again maximizing vision. So it reduces the tumor moves away from the fovea macula, and also subretinal fluid regresses fairly rapidly. These are the mechanisms. Okay. Now, intravenous chemotherapy was world over the standard of care in early 2000s. No longer so, intraarterial chemotherapy has taken over, but in India, because of resource crunch and the expense that intraarterial chemotherapy has, we still use intravenous chemotherapy quite substantially. High-dose intravenous chemotherapy is relatively more effective than standard dose intravenous chemotherapy, specifically for group D and E retinoblastoma. This is one concept. Before intraarterial chemotherapy, this was quite in vogue. Now with intraarterial chemotherapy being in place, high-dose intravenous chemotherapy is no longer used so much for intraocular tumors, but for orbital RB, this is one of the treatments of choice. This is an example of a child with high-dose intravenous chemotherapy has done fairly well. Now about intraarterial chemotherapy. In intraarterial chemotherapy, you need the help of an interventional neuroradiologist and a team. And generally, this procedure is done in a cath lab where a 400 micron catheter is inserted to the ostium of the ophthalmic artery. You simply peep into the ophthalmic artery, then we inject these drugs. Injection of the drug has to be in a pulsatile fashion, and it should be ideally done by an ocular oncologist or a trained oncologist. Not necessarily an ocular oncologist would also do, or an interventionalist himself or herself can inject these drugs depending on the situation that you're working. But in any case, we can use up to 3 drugs. If somebody asks you what is the drug of choice, of course it is melphalan. Melphalan is the workhorse drug in intraarterial chemotherapy. That is the drug that is used in a majority of centers, but you can definitely add on topotecan and carboplatin to melphalan to make it a triple drug intraarterial chemotherapy. The advantage of using 3 drugs is that the initial response is going to be very substantial and fairly quick. So if you want to limit the number of cycles of intraarterial chemotherapy, you can use 3 drugs. If you have the resources to do 6 or even 9 cycles of intraarterial chemotherapy, then you can use melphalan alone. But in India, we would prefer 3 drug intraarterial chemotherapy, and that's what we have been practicing. And the response to intraarterial chemotherapy is very rapid. This is one patient where after one injection, you can see that the total exudative retinal detachment is completely settled and the tumor is nearly totally calcified. Another example where there is bullous retinal detachment completely settled and you find a nicely calcified tumor. So very substantial response, very quick response. Intraarterial chemotherapy works very well in primary RB, as you see here, and also in a recurrent situation. This was a calcific tumor. On top of that, there was a recurrence, and you can see nice response with intraarterial chemotherapy. So it works very well, and its effect is very pronounced in group D and E retinoblastoma. If it is group A, B, or C retinoblastoma, intraarterial chemotherapy does not have any added advantage over intravenous chemotherapy for tumor control alone. Nearly 100% response. But for group D and retinoblastoma and group E retinoblastoma, it provides an additional eye salvage rate of about 10 to 15%, depending on the situation. It is in a kind of a multi-specialty practice where you have a team approach. If you have a good interventional neuroradiologist or an interventional radiologist, you can have them trained very easily. And in our situation, in the last 100 consecutive cases, 98% was the cannulation rate, and only 2 were balloon, and they find alternative ways to canalize and get access to the ophthalmic artery. Cost is the only barrier. Complications are mainly overcome already, and there are hardly any complications of intraarterial chemotherapy, although there are rare reports of neurovascular complications and ophthalmic artery occlusion, etc. But those have become extremely rare. Cost is the only barrier currently. So for conclusion for IAC is that it does make a difference for group D and E retinoblastoma and for large recurrences. The next part is about the vitreous seeds. Vitreous seeds are the major bugbear in the management of retinoblastoma. Vitreous seeds form either by break or breach in the internal limiting membrane and growth of these cells into the vitreous cavity, or by sprouting of the vitreous seeds from an endophytic tumor. Now, once these cells come into the vitreous, there are two mechanisms. One is adherence-independent growth. Majority of this work has been done by Dr. Francis Munia. He's worked extensively on vitreous seeds, and due credit to him. Adherence-independent growth is these seeds is that the seeds are capable of deriving nutrition from the vitreous. So they are able to multiply while being in the vitreous cavity, and they're free floating. So basically, free floating seeds in the vitreous cavity are by adherence independent growth. They don't need a retinal substrate to grow. Other seeds may not be able to survive with the nutrition that is accessible to them in the vitreous cavity. They may have to settle down on the surface of the retina to grow. This is called adherence dependent growth. So these typically form epiretinal seeds. They settle down on the surface of the retina and then they proliferate like so, and that is called epiretinal seeding. So epiretinal seeding is a form of intraocular seeding. We don't call them vitreous seeds anymore. We call them intraocular seeds. Vitreous seeds are one specific form of intraocular seeds. Epiretinal form seeds are the other specific form. There are many other types of vitreous seeds as well. One is classic vitreous seeds, as we always knew. The next is prehyaloid, subhyaloid, epiretinal, intraretinal, subretinal. These are all the forms of intravitreous seeds in the posterior segment. Now in the anterior segment, we have intracameral, which are depository, which simply come through the zonules and settle in the anterior chamber, or infiltrative, which are contiguous through the ciliary body, trabecular meshwork, iris, get infiltrated, and then the seeds are there along with that. So there is a very nice classification now on intraocular seeds in retinoblastoma. Some of this is OCT based classification. These pictures are from Munia. Very nice pictures. You can see representative seeds, subhyaloid seeds, prehyaloid seeds I already showed, intraretinal and subretinal seeds, depository anterior chamber seeds which come through the zonules and settle in the anterior chamber without any infiltrative component, and the infiltrative anterior chamber seeds, you can see that there is a squaring of the edge of the pupil. So that's a sign actually. Pupil has to be nice and round And if one of the edges of the pupil is squared, it's called D-shaped pupil, look for iris infiltration in the contiguous area, or for anterior chamber infiltration, trabecular meshwork infiltration in that particular area. So any distortion of the pupil or straightening of the edge of the pupil is a sign that there could be anterior segment infiltration, and you have to do an thorough examination under anesthesia and perhaps a UBM to see if there is any occult anterior segment or ciliary body invasion. Morphological classification: dust, as the name implies, dust-like vitreous seeds. Cloud is a sheet of vitreous seeds which obscures the view of the fundus. That's a cloud of vitreous seeds. Sphere is the most classic form of vitreous seeds, and a mixed appearance where there is bit of this and bit of that. So how do we manage vitreous seeds? Whenever there's a viable retinal tumor and vitreous seeds, you don't enter into the vitreous. You don't treat them with intravitreal chemotherapy if the retinal tumor is large and is viable. Then you give chemotherapy, either IVC or IAC, and along with that, to increase the intravitreal concentration, you can give periocular chemotherapy. When the retinal tumor is nearly regressed and you have viable residual vitreous seeds, then you bring in safety enhanced intravitreal chemotherapy. So this has to be very clear. If there is a large retinal tumor which is active, then you don't want to enter into the vitreous cavity because of the fear of extraocular extension. But when the retinal tumor has nearly totally regressed, then you enter into the vitreous. For periocular chemotherapy, it is deep posterior subtenance chemotherapy, for which use either carboplatin or topotecan. Carboplatin is no longer used because of the scar fibrosis that it produces. Topotecan is quite safe to use in deep posterior subtenance location. This is from our earlier study. When we used carboplatin, it did show good response along with high-dose chemotherapy. You can see all these vitreous seeds completely gone. No intravitreal chemotherapy was in vogue at that time. This patient was totally treated with intravenous chemotherapy and periocular chemotherapy. This we had published earlier. Now with periocular topotecan, we have about 70%, 68% remission with just systemic chemotherapy and periocular topotecan for vitreous seeds. So about 30 to 35% of these patients may need intravitreal chemotherapy. Others can resolve just with systemic chemotherapy, intravenous or intraarterial, along with periocular chemotherapy. So we have a good use for periocular chemotherapy as well. For residual vitreous seeds, as I said, intravitreal chemotherapy is used. These are the criteria. Retinal tumor should not be large. We have to choose a safe site. Best safe site is 180-degree away from the location of the vitreous seed or the tumor. It is not easy for us to find a location which is exactly 180-degree away. Sometimes you have to settle for 1 or 2 clock hour gap between the last vitreous seed and the safe site. So farther the better, that is the idea. Exit through eyes. You freeze the needle tip as it is still in the vitreous cavity with a large diameter cryoprobe, and the ice ball is allowed to form around the entry point of the needle, and through the ice ball you withdraw the needle and continue with injection site cryotherapy for thrice over. So you cryo the point of entry and exit. Death by water is a technique where you use distilled water, pool it in the cul-de-sac, and that is supposed to cause cytolysis of any tumor cell that has escaped the confines of the vitreous and is present in the cul-de-sac. So this is to prevent the occurrence of extraocular extension. And there's also a technique where you raise a small bleb of subconjunctival topotecan in the area of injection. So this is all to make the procedure as safe as possible. You have to enter with the bevel of the needle pointing towards the vitreous, not towards the lens, so that you avoid cataracts, etc., etc. And after you inject, you have to gently kind of move the eye several times. This is called jiggling of the eye so that the topotecan distributes equally well in all parts of the vitreous cavity. You can also, topotecan appears little bluish greenish when you use a cobalt blue filter, and the uniform appearance of this greenish or bluish color indicates that it is distributed through the vitreous cavity quite thoroughly, and that's one indication that you can use. Another is a selective intravitreal injection where you go exactly close to the vitreous seed and inject. So this is also in vogue by certain groups where they go into the vitreous cavity, localize the clump of vitreous seeds which need to be treated, and go towards them or go very close to them and inject intravitreal topotecan. But we generally inject in one safe site and make sure that the drug is as thoroughly distributed all through the eye as possible. 30 was the dose, that microgram was the dose that we started off with. Then we escalated to 60, and currently we, for diffuse seeds, we use up to 90 micrograms. This was the first case that I treated. At that time, I used melphalan, and it gave very good results. All these 5-6 seeds that were there went away completely with intravitreal melphalan. We were very happy. This was one more case where intravitreal melphalan was used. But as we started using more and more melphalan, we realized that there's a unique complication in Asian and Indian eyes, which is RP atrophy. As you see here, there's extensive atrophy of the retinal pigment epithelium, which can sometimes preclude good vision. Apart from this, we also started finding uveitis, cataract, and also there was this classic need for weekly injections, making it a logistical nightmare to bring these children every week to inject, need for multiple injections and potential retinal toxicity. So we shifted to intravitreal topotecan. Now, this is the latest study that we have published on topotecan. This is long-term results of intravitreal topotecan in 91 eyes. I've highlighted the findings. Median number of injections that were required were 3. That means with 3 injections in a majority of patients, we were able to control these vitreous seeds. And the number of injections dependent on the type of the vitreous seeds. 2.5 injections for dust. That means that dust go away very fast. 3 injections for sphere. Spheres are also reasonably good. But for cloud, the number of injections is mean of 5. So clouds are the most difficult form of morphologically difficult form of vitreous seeds to kind of take care of. Vitreous seed regression was achieved in 97% of the eyes, and 85% as eye salvage. 85% eye salvage is not because of vitreous seed recurrence, it's because of the retinal tumor recurrence, etc. But then vitreous seed regression was 97%. This is a long-term study that we have recently published on topotecan. 30 microgram initially, 3 weekly. Now we go up to 60 or even 90. This is one more example of a topotecan, 2 doses of intravitreal topotecan, and all these seeds have gone away. This is a good clump of seeds which have gone away after 2 doses of intravitreal topotecan. Spheres gone away. It's very useful. You can see this cloud gone and completely calcified areas that are being revealed after clouds are gone. This is a combined intraocular seeds, which is epiretinal and some intraretinal, subretinal seeds. All of them have gone away with intravitreal topotecan. In refractory situations, we use topotecan in combination with melphalan. This was a patient where after systemic chemotherapy, that was a tumor went away, and the vitreous seeds nearly totally remained. After 6 injections of intravitreal topotecan, vitreous seeds have come down, but they're still there substantially. That's a cloud. And after we added melphalan, that also went away. But you can see that there is retinal pigment epithelial atrophy that has set in. So melphalan does produce retinal pigment epithelial changes, and that is a problem. We can reduce melphalan to further low dosage along with topotecan, but then the effect may not be so good as we see here. Now, there is a regression pattern of vitreous seeds that is also described. Complete disappearance is called type 0. Conversion into calcified seeds is called type 1A, or crystalline refringent dust is called type 1B. Amorphous non-spherical seeds is called type 2, and combination of regression types 1 and 2 is called type 3. Now, how does a vitreous seed get calcified? It can get globally calcified. That means that it will form a nice chunk of opaque calcification. That's one way it gets calcified. The second is a peripheral rim of calcification. That means eggshell kind of calcification. The central core will remain transparent or slightly translucent, but then the calcification will be at the edge. The third way it gets calcified is that there is a thin peripheral rim and there is a small dense dot within the vitreous seeds. That's the third way it gets calcified. Fourth is very irregular shaped calcification. That is what is called amorphous or non-spherical seed. So the many ways these vitreous seeds regress. These may not be the only 3 types of regression. There may be many more types of regression, but this is what has been described by Munia. We can keep on adding to it, but we should always look for change in morphology, change in the extent of calcification, change in the number of seeds itself or the extent of seeds to judge whether they're responding or not. So there are many factors that we look at when we judge whether a intraocular seed has started regressing. This is just the pictorial depiction of what I described already. Now, extending indications for intraocular chemotherapy for anterior chamber seeds, we can give intravitreal chemotherapy if there are concurrent vitreous seeds as well. Otherwise, we can use intracameral chemotherapy as well. So this is a patient where anterior chamber seeds were treated with topotecan 5 microgram intracameral. There's also bicameral chemotherapy that's been described by Munia, where both anterior chamber and the posterior chamber get these injections for good, better effect. And that's a slightly complex maneuver that you need to give posterior chamber injection. Anterior chamber injection is fairly easy, and that is to be practiced and perfected. For patients who have subretinal seeds, again, you can give intravitreal topotecan, and this is an example where there is nice regression of subretinal and epiretinal seeds with topotecan. Earlier, we would laser them. Lasering these would mean a large scar like this. Obviously, vision will be affected, and with intravitreal topotecan, macula is fine, and there is very subtle RPE change in the area where the seeds. One more example of subretinal seeds, epiretinal seeds completely gone away with intravitreal topotecan. We are even treating small endophytic tumors, 2-3 millimeter tumors with intravitreal topotecan. Currently, this is still under trial, not yet published. Chemoplaque is coming. Chemoplaque is a way where there's an extraocular drug delivery matrix that is affixed to the sclera from outside, and that will continue to release topotecan over a period of time, and that is supposed to have a sustained benefit in terms of regression of vitreous seeds. It is still in work. It is not commercially released, as I know. So RB seeds are nearly totally conquered finally. Going on to enucleation. Enucleation, you see that there is a change in trend. Currently, we do very few enucleations, but it is still the treatment of choice for advanced unilateral retinoblastoma, retinoblastoma with neovascular glaucoma, and anterior segment infiltration. So these are the cases where you would want to do primary enucleation. Any patient with anterior segment infiltration, ciliary body infiltration, hyphema, vitreous hemorrhage, buphthalmus, sterile inflammation, etc. So you would primarily do enucleation in them. Neoadjuvant chemotherapy before enucleation, there is no substantial role as far as the life salvage is concerned. But if a child comes to you with a clinical appearance like this, where there is sterile orbital inflammation, doing primary enucleation would be very difficult. One is that it will bleed. Second, there is a chance of scleral perforation. And also because of bleeding, you may end up getting a smaller optic nerve stump than you wanted. So in such situations, it's best to control inflammation and then do enucleation. Other reasons are that the family is not yet ready for enucleation. Then you give them time to mount the eye and start off with intravenous chemotherapy. And when they're ready for enucleation, you perform it. But if that is the situation, if we need to initiate it, it should be completed until 6 cycles. Because if you start chemotherapy and then do enucleation after 2 or 3 cycles, the choroidal invasion that was there earlier may have gone by then. So you will get downstaging of the disease on histopathology. So there is a risk of microscopic metastasis or micrometastasis because the choroidal invasion was already there and the child received incomplete chemotherapy, thus predisposing the child to systemic metastasis. So if you start chemotherapy, then it should be completed for 6 cycles. If a patient has optic nerve invasion beyond the lamina cribrosa, we generally start on neoadjuvant chemotherapy to downstage the disease and then do enucleation. The technique of enucleation is fairly refined. It's the minimal manipulation technique, avoiding accidental perforation. We aim for a long optic nerve stump up to 20 millimeter. We don't stop at 15, but 10, as described in the books, is definitely suboptimal. Example is this patient where there is optic nerve invasion. As you see, if I were to cut it at 10, obviously I would leave some tumor behind. But having got 15 millimeter stump here, there is no transaction edge positivity. Primary implant is mandatory, otherwise the children will not get the cosmesis that they deserve, and parents will not be happy with the cosmesis unless you provide a primary orbital implant. And whenever you provide a primary orbital implant, it has to be silicone or PMMA, not an integrated one. Now, this is the technique of enucleation that we follow to get a long optic nerve stump. This is a myoconjunctival technique that we use. This is a 4-year-old child with unilateral advanced retinoblastoma where we are doing this procedure. Small lateral canthotomy is performed. Peritomy is done as close to the limbus as possible with a blunt-tipped conjunctival scissors. Then tenons is dissected in oblique meridia between the recti. Tag sutures just short of the insertion of extraocular muscles with a 4-0 silk. Second tag suture with 6-0 vicryl 6 to 8 millimeter distally, and the muzzle is disinserted between these two sutures. Each recti is treated similarly. Superior oblique and inferior oblique are simply hooked and disinserted. This minimizes bleeding, makes visualization perfect. Small lateral relaxing incision in the conjunctiva. Let the eyeball prolapse through the blades of the speculum so that the optic nerve remains stretched. You don't have to pull the eye so much. Then you use a semi-curved tenotomy scissor. Strum the optic nerve, reach the orbital apex, lift by 2 millimeters so that you don't cut through the structures of the superior orbital fissure, and then cut. Then once you've enucleated, you identify any potential areas of risk factors. See, the optic nerve stump is 19 millimeter without much effort. Implant is placed posterior to posterior tenons being held up by the assistant. Then the tenons is closed, posterior tenons is closed with 6-0 vicryl sutures, multiple sutures so that it is secure. Myoconjunctival technique would involve passing sutures just short of the fornices. 6-0 vicryl sutures, 4 such sutures. Then the anterior tenons is closed, again with secure 6-0 vicryl sutures. And finally, conjunctiva is closed by continuous key pattern suture, where the edges of the conjunctiva remain opposed and there is minimal risk of implantation cyst formation. Conformer is mandatory, 24 or 26 millimeter, and a suture tarsography just for the purpose that the child should not pull out the conformer or the fornices get compromised. So these were the tips. Lateral canthotomy and a relaxing incision optional. Make sure that the extraocular muscles are transected completely before you start the process of cutting the optic nerve. Prolapse the eyeball and use minimal traction through traction sutures. This is to stretch the optic nerve. Avoid enucleation, spoon or scissors. For the lateral approach, use a 15-degree curved tenotomy scissors. For the medial approach, since the medial orbital wall is straight, you have to use a straight scissors. For the lateral approach, you use a semi-curved or a 15-degree curved tenotomy scissors. Strum the optic nerve and reach the orbital apex. You would get a hard bone stop. Then you lift the scissor by 2 millimeters and then cut. Don't cut at the orbital apex because then you'll be cutting through structures that pass through the superior orbital fissure if your approach is lateral. And also there will be very brisk bleeding if you cut right at the orbital apex. So cut it about 2 millimeter higher than the apex. Very critical cases where you have to cut at the orbital apex, then I have even done a bone cut to get access to the orbital apex, but that is extremely rare. Now, optic nerve stump is very important. Anything less than 10 millimeter is not ideal at all. 15 to 20 millimeter is ideal. And apart from that, I would want to emphasize the fact that you have to mark areas of potential histopathological risk factors. A dilated vertex vein such as this, a bluish sclera, thin sclera, sclera that is vascularized, unduly vascularized or thickened, indurated sclera. All these are to be marked and the pathologist has to take sections through these to see if there are any histopathological risk factors. Apart from that, the pathologist has to take not just the pupilo-optic callet, but the lateral callets as well. Suppose this is the eye. They take what is called a pupilo-optic callet, pupil to optic nerve. Apart from that, the current protocol is to take lateral callets as well and predloaf them so that these sections are completely studied for histopathological risk factors. If you don't do that, then there is a high risk of metastasis. And the risk factors are present in more than 50% of children who undergo enucleation in India. These risk factors are iris and anterior segment infiltration, ciliary body invasion, as you see here, choroidal invasion, which is more than 3 millimeter in diameter and 3 millimeter in thickness. That's called major choroidal invasion. Optic nerve invasion beyond the lamina cribrosa and extrascleral extension. So in all these patients who have any of these histopathological risk factors, we have to provide them with adjuvant therapy. And that adjuvant therapy could either be chemotherapy or radiation. For this specific group of patient where there is extraocular extension or optic nerve transaction involvement or full thickness scleral invasion or extrascleral extension, then you have to give adjuvant orbital radiation. For all others, we give adjuvant intravenous chemotherapy. There were controversies in the literature earlier, but it is more or less settled with this article, which was a large series, where we showed that if adjuvant chemotherapy is not given, then the risk of metastasis is 24%. Whereas if you have identified these high risk factors and have given adjuvant therapy, then the risk of metastasis is only 4%. Means that you're benefiting at least 20% of children by providing adjuvant chemotherapy following enucleation and identification of histopathological risk factors. This information was further corroborated by a large multi-centric study done by the Children's Oncology Group, where their findings were nearly similar. So enucleation is not the end. What is mandatory is the identification of histopathological risk factors by a standard pathology protocol by a trained ophthalmic oncopathologist or a pathologist who's oriented to ophthalmic oncopathology and provision of further treatment. The last part of it is about orbital retinoblastoma. Now, orbital retinoblastoma is stage 3A and in TNM classification, CT4. And clinically, we have primary orbital retinoblastoma where no prior treatment has been given and the child manifests with orbital RB. Secondary is when the tumor recurs following enucleation. Sometimes radiologically also you can identify orbital tumor which may not be clinically apparent. This is a secondary orbital retinoblastoma where following enucleation the tumor has recurred. Accidentally is when somebody does an intraocular surgery in an eye, unsuspected retinoblastoma, and the tumor comes out of the eye, and that is extraocular extension. Overt is when radiology does not even show that there is a small scleral nodule, but on enucleation you find that there is an extraocular extension. Microscopic is when the pathologist tells you that there is full thickness scleral invasion or extraocular extension or optic nerve invasion to the transection. All this is orbital RB, carries a very high mortality of 50 to 70%. So we use multimodal treatment here. Multimodal treatment is nothing but a combination of chemotherapy, surgery, and radiation in a specific order. So how do we go about it? This is a child I'll show with orbital RB, and that is the orbital component. We start this child on neoadjuvant chemotherapy. After 3 cycles, the orbital component has completely resolved. So we take radiological guidance to estimate whether the orbital component has resolved. Clinically, of course, the eye has gone into phthisis, so it has resolved. So once on radiology, we are sure that the orbital component is resolved, we do a standard enucleation with a long optic nerve stump, and anything adherent to the optic nerve will also be removed. So that's called en-bloc enucleation. If the conjunctiva is adherent to the eyeball, that is also removed with the eyeball. So en-bloc enucleation is performed, and then stereotactic radiation is delivered to the orbit to take care of the microscopic residual within the orbit. And for the systemic micrometastasis, we provide adjuvant chemotherapy. Totally, the child gets 12 cycles of chemotherapy, 3 to 6 before enucleation, 9 to 6 after enucleation, and adjuvant radiation as well. So surgery, chemotherapy, and radiation. It works well for optic nerve invasion. You can see optic nerve invasion regress following neoadjuvant chemotherapy. For intracranial extension to the cavernous sinus, you can see nice regression here. What is left is at the superior orbital fissure, very easily amenable to radiation. Cosmesis is a good bonus these children can enjoy. You can see that orbital exentration was not necessary in this child, and the child has a nice prosthesis. Lid infiltration already, but the child did not need any exentration. You can see nice flat lids and a well-centered prosthesis in a secondary RB. So orbital RB also now has a cure. With all this put together in India, currently we have more than 95% life salvage. It is approaching about 95 to 97% currently. In some centers, 98%. Overall, about a third of patients may need primary enucleation. Chemoreduction produces, or neoadjuvant chemotherapy produces 90% eye salvage. 95% have some vision, and wherever vision is measurable, about half of them have very useful more than 20/40 vision. Socioeconomic barriers to care, there are challenges and solutions as well. We can provide help by using NGOs and governmental support. Cost-effective management protocols, of course, make it very economical to treat retinoblastoma. If you were to give chemotherapy in an ophthalmic setting with the help of a pediatric oncologist and use multi-dose vials, then the cost of chemotherapy can be reduced substantially. With all this put together, we have more than 90% compliance success. Seema already mentioned that we have a very high compliance success in retinoblastoma because we actually chase these patients and get them back if they were to go missing. Future prospects, of course, the role of genetics cannot be overemphasized. Campaigns to provide early diagnosis, awareness among pediatricians, ophthalmologists, and paramedical personnel, optometrists, improved focal therapeutic measures by using transpupillary thermotherapy and synergistic ICG and STT. Focal drug delivery systems can be further optimized. Of course, advocacy at all levels. This is something that is happening, non-invasive pre-implantation genetic testing. This can get rid of retinoblastoma from families by using selective fertilization, in vitro fertilization, awareness programs on leukocoria. This was a campaign that was done in Mexico that helped increase pickup of retinoblastoma by many folds. There are apps as well. There are many apps that can help you pick up leukocoria. These are available. Anybody can download it and use these apps to see if there is any real leukocoria or pseudoleukocoria. So coming from the depth of information about retinoblastoma to the surface, summarizing everything, we have much better life salvage because we have identified the role of neoadjuvant chemotherapy. We have specified the role of adjuvant treatment, radiation, and adjuvant chemotherapy, and the use of multimodal treatment in orbital retinoblastoma has pushed up survival to 95 to 98%. For eye salvage, we have used intraarterial chemotherapy and extensively intravitreal chemotherapy and selectively brachytherapy, which has resulted in 80 to 90% eye salvage. For vision salvage, intraarterial chemotherapy and intravitreal chemotherapy, especially topotecan, has specifically helped for vision salvage. But more importantly, selective use of ICG-enhanced TTT and TTT itself have also enhanced the possibility of vision salvage. So summarizing the management modalities for Group A, it's mainly focal therapy that we depend on. Group B, we classify them as visually critical and visually non-critical. If it's visually non-critical location, then we can use focal therapy. But if it's visually critical location, then chemotherapy is the ideal initial treatment, irrespective of the size of the tumor. Even if it is a 3 millimeter foveal tumor, then for the sake of vision, you would still want to give chemotherapy. Group C, D, and E tumors, chemotherapy plus local and focal therapy. Bad E, that means, well, eye salvage is possible, maybe remotely, but there is no vision salvage possibility at all. Then you would prefer enucleation and histopathology guided adjuvant therapy. Stage 2 retinoblastoma, that means there is microscopic residual. Then you would give adjuvant external beam radiation plus chemotherapy, or combination of the two, as I already mentioned. And stage 3 retinoblastoma, multimodal therapy, chemotherapy, radiation, and surgery. Stage 4 retinoblastoma, where there is metastasis already, then use multimodal therapy or palliative care depending on the situation. So these are some of the children who are survivors of retinoblastoma. How much vision do you expect in this child? Such extensive scarring, but he's able to use whatever vision he has to draw well. These are children who are good at music. She has a macular scar, but look at the way, she is handling this instrument. And this is a child, she's already playing the role of a teacher with one eye. These are actually grow up like normal children and they do very well in life. This sound is heard, Rolika? Okay, fine, no problem. So in conclusion, I would say that cost-effective protocol-based management by a multidisciplinary team, where ocular oncologist is a major part of the team, and of course, oncologist, geneticist, everybody would, pathologist, of course, most important role, all of them would be part of the team, but it has to be led by an ocular oncologist who is familiar with the way retinoblastoma manifests and way it is focally treated. And he takes the help, or she takes the help of everybody else to take care of retinoblastoma. It said that the management of retinoblastoma needs a village, right? So a whole lot of people come in to help the management of retinoblastoma, and NGOs play a very important role in mobilizing support for these children and their families. Finally, we achieve excellent life salvage up to 98%, eye salvage over 90%, and excellent vision salvage as well, even in developed countries with the use of minimal resources. Thank you so much.
Thank you so much, sir, for a perfect overview of retinoblastoma. And it's so important for us to understand the importance of an ocular oncologist and the entire well-established referral and timely referral for early detection of these children. Thank you for highlighting that, sir. And we have few questions. One of the questions from Mr. Farhan Siddiqui is that how many MRIs should be done in the treatment of retinoblastoma? How many for an intraocular RB and how many for extraocular RB?
Well, for intraocular retinoblastoma, we just do a screening MRI. And if the screening MRI does not show optic nerve extension, extraocular extension, choroidal invasion, we don't do any more. We don't do any more at all. But if the child has extraocular retinoblastoma already on screening MRI, then at the end of 3 cycles of neoadjuvant chemotherapy, we repeat the scan to see if the extraocular component has regressed, because we have to plan our surgery. If it has not regressed, we go on to give additional 3 cycles of chemotherapy, and then we repeat the MRI and so on. And if the child has orbital retinoblastoma, of course, MRI has to be repeated at least for 3 years. Periodicity depends on the risk, so that if there is any early recurrence, it is detected. And if optic nerve is involved, and if there are signs of optic nerve sheath involvement, then MRI monitoring has to be very stringent, because then these children have a high risk of meningeal retinoblastoma. So optic nerve sheath enhancement on MRI is taken very seriously. Optic nerve sheath involvement is taken quite seriously.
Right, so basically there's no specific regimen, it depends on a tailored management overall.
Yeah.
Right, so another question, sir, that over your experience of so many years, you must have seen a shift that has occurred from orbital retinoblastoma to early detection. What would you like to comment on that? Have you seen a change in the Indian scenario?
It's happening as we speak. In fact, before you came in, I think Seema presented very good data showing that there's a north-south divide. In the southern part of the country where there are more ophthalmic institutes and the awareness possibly is higher, we have very few orbital retinoblastomas now, whereas in the northern part of the country where the spread of the institutes or accessibility may be suboptimal or there is a higher live birth rate, the chance of orbital RB is higher. Awareness is also obviously lacking in some parts of the country. So wherever there is poor awareness, poor accessibility, poor socioeconomic standard, orbital RB still predominates. Wherever the socioeconomic standards are reasonably good, awareness is good, and the access to care is there, then orbital RB is much less.
Right. So another question is that, is there any app or this is a question by Dr. Nilima Thakur, and she's asking that, is there any app or tool available for early detection or screening of children with RB?
There is just an iPhone and an Android app. There are many of them actually. I showed some and I can put it on YouTube, links to it in the chat. But basically, these can be downloaded by parents. This is not for an ophthalmologist because ophthalmologists are able to identify it very easily. This is for parents or paramedical personnel where they take a picture of the child. And if there is leukocoria, the app does post-processing of the image and it will only flag a reliable leukocoria. Sometimes because of the reflex itself, you find the abnormal pupillary reflex in a kind of situation where the pupil is slightly dilated. Suppose the room is dark and you take a picture, and for the moment the pupil is slightly dilated and you get a reddish reflex from the eye and an abnormal reflex from the eye depending on the head posture of the child. Some parents are concerned about it. So if a parent is concerned, before he takes the child to a pediatrician or an oncologist, they can use the app to flag out if the reflex is of concern or not. Paramedical personnel who may not be very familiar with the white reflex can also use the app from their mobile phone to see if the reflex is of concern, and in such situations they can refer the child.
Okay. Another question, sir, that would be for you and even Seema ma'am, that would be that how do you handle, in your practice, how do you handle the system of defaulting? What is your protocol of combating the defaulter system, the defaulters in retinoblastoma?
We chase them. Counselors first call them. And if they respond, we try to find out the reason. Is the reason financial? They're not able to travel sometimes. Is it social? Is it financial, or a combination of both, or simply neglect? If it's neglect, obviously we have to appropriately counsel them. If it is social reason, again, we have to do a lot of counseling. If it's financial, then it is very easy to solve because simply give them financial help and they come. That's the easiest of all the causes for defaulting to solve. If there's a deep social reason, if they're very worried about enucleation, and enucleation is a social taboo in their community or environment, then we can let them understand, over a period of time, or realize that the child ultimately will need enucleation perhaps, but we can start them on neoadjuvant chemotherapy and let them settle down to the idea of enucleation of a blind eye, right? So there are many situations which have to be handled differently.
Right, so, and the last question is that what would be your suggestion for general ophthalmologists when they are not able to visualize the posterior segment in a child, like in a pediatric age group? Because very often we see patients who are treated with a vitrectomy in an eye where they couldn't visualize, maybe due to a dense cataract or maybe due to cornea being hazy. What would be your suggestion to them so that we can avoid an orbital retinoblastoma, an inadvertent one?
Right.
Accident.
So there are 3 or 4 clinical situations, one of which is hyphema. If there is spontaneous hyphema, then before draining, or trying to drain, they should definitely do a B scan, ultrasound B scan, that too with immersion. If you don't do immersion, an anteriorly located tumor can be missed. Perhaps it's not retinoblastoma, it could be medulloepitheloma, but still it's the same, right? It's a tumor. So a good imaging is mandatory in a child with hyphema. Even if there is a clear history of trauma, there should be good imaging, before which you cannot do an intraocular surgery. If there is unilateral dense cataract, even if you think it is developmental cataract, without doing an imaging, you should not operate a pediatric cataract. Posterior segment imaging is mandatory before you operate pediatric cataract, because in pediatric cataract surgery, they do primary posterior capsulotomy with anterior vitrectomy. And what if the retinoblastoma is lying behind? Right? So it's important that they do imaging in cataract as well. So hyphema, cataract, they have to do imaging. Now the third situation is vitreous hemorrhage. In vitreous hemorrhage, even if there's a history of trauma, there's a need for good imaging and even a CT scan or an MRI. There is no reason a child should have spontaneous vitreous hemorrhage. The next is endophthalmitis. Endophthalmitis is a situation where they would immediately do a vitreous biopsy and vitrectomy. And that could be a situation where there is, say, necrotic retinoblastoma, which may not be easily picked up on imaging. Correct? Necrotic RB may lack the typical features on imaging. So whenever they have to do vitrectomy in a situation where there is what looks like endogenous endophthalmitis, not an obvious reason is not there for endophthalmitis, it could be looking like an endogenous endophthalmitis, then they should not do peritomy. They should do vitreous biopsy through one point, ideally the small gauge vitrector, and then not just send it for microbiology, send it for cytology as well, so that they don't miss this retinoblastoma. So these are the situations that we have come across. Mainly it is the vitrectomy that they do for vitreous hemorrhage, vitrectomy that they do for what they think is endophthalmitis, or the cataract surgery that they do for what they think is developmental cataract, and then primary posterior capsulotomy and anterior vitrectomy where we have detected retinoblastoma later. So if they can avoid that, that will be great.
Right. So, and I think I will just add to that part is that I really appreciate how our colleagues from vitreoretina or from cataract, when they do a B scan, they send it to us for review, even if they're not sure. And I think that's a very good idea to send a B scan,
Take opinion.
provisionally.
Yeah, if you have any
take an
confusion at
opinion.
all, take an opinion.
Exactly. Thank you so much, Aduzva. That is an end to all our questions, and over to you now.
That's all. I just want to thank everyone, especially Poonam Bagai and Seema, for their initial 2 talks, which are great. And I thank all the listeners. This is, again, to emphasize, this is a Pediatric Cancer Awareness Month, September. And awareness is at all levels, not just the parents. Parents are, of course, responsible for their children, we all realize. But parents should know the importance of leukoporia and squint. And there comes our role. And paramedical personnel, whoever is attached to you as a pediatrician, oncologist, or an ophthalmologist, your optometrist should know, your office staff should know. And of course, we should also know that squint can be dangerous. Squint, of course, can be because of other reasons. But if a child has squint, then you should not leave the child go out of your office without a fundus evaluation. Any child with squint, dilated fundus evaluation is mandatory. Any child with leukoporia, immediate referral is mandatory, even if it could be pseudoleukoporia, that's fine. Lens is not the cause, but then the child has leukoporia, definite referral is warranted to a retina specialist or an ocular oncologist. If it is upfront retinoblastoma, of course, it has to go to an ocular oncologist who is trained to handle retinoblastoma. That's all I have to say.
Right. Thank you. Thank you, everyone, for listening. Have a great night.